Hello, PIH in Whittier, California. This is Elizabeth Tolmich Searle presenting my in-service on communication to build rapport and patient adherence in their therapy programs, and how we might modify our communication when we have patients who are demonstrating catastrophic thinking and behavior with their pain and in their treatment plan. I look forward to presenting the rest of my presentation. If you have questions, feel free to email me, and my references are attached at the end of this presentation. Enjoy! As I read through some of the research articles that have studied how to communicate to build rapport with patients, I found the list of important ways to communicate with patients to be somewhat seemingly second nature. I look at this list and I think, yeah, this makes sense. However, what I found in my clinical rotation is that putting this to practice is actually really challenging at times when you run out of time with patients, when patients come in with certain fears or different affects, different things going on in their lives that are stressful. This list is no longer straightforward, and we have to be able to meet the patient where they are and meet our performance requirements as physical therapists. We have to be on time for the next patient. So not rushing patients out the door when they're trying to bring up something important last minute is really important to patients. And so how do we manage this as physical therapists? And this has been a big challenge for me and quite a learning experience in this clinical rotation. Along with this list of ways to connect with patients, like being friendly, repeating what you hear from them to let them know that they have been heard and understood, trying to explain their diagnosis simply, and acknowledging that they have values and preferences. Besides this list, through our communication, teaching patients how to build goals, how to create action plans, instructing them in their exercise program, providing cues and feedback, allowing them some practice in the therapy session so that they can go home and try to master these things outside of the clinic, grading exercises based on where the patient is, making it harder or easier, and then encouraging patients to reward themselves when they do things that lead to behavior change, had a larger effect size at follow-up in some of these studies. One article that I looked at compared recommendations from clinical practice guidelines in treating musculoskeletal pain and compiled a list of recommendations that kind of came up over and over. And I pulled a few that related back to communication. And one of the things that was important is providing information to patients about how they can be independent in bettering their health. So giving them the tools, resources, information, and knowledge so that they can go home and advocate for themselves, make better choices, and understand why they would want to make better choices in the first place. And this information is best presented in a very simple manner. The patient needs to be able to say their understanding back to you in a simple way. And that's how you know that you communicated to them clearly. And when we talk to patients about things like their mental health and their prognosis and what are their lives going to look like 3 years down the road? What do they want their lives to look like? I think that can be done effectively using skills like motivational interviewing, which we're going to look at here in a few slides. But asking questions that get people thinking. If you choose not to continue with physical therapy and choose not to make change, what will your life look a year from now? And what if you did try something different and it was challenging, but you tried it anyway? what do you imagine your life looking like a year from now, and how is that different? And what do you want your life to look like a year from now? Starting to get patients to think about alternatives and using their imagination to inspire themselves to make better choices in their health journey is really important. And so this article that came up with some of the consistent recommendations highlighted these three things that I felt related to communication that would promote patient adherence and rapport. Pain neuroscience education is used for addressing fear avoidance behavior and catastrophic thinking. It is really a tool to normalize patients' pain so that they can move forward from there and have confidence in being active and moving despite feeling this pain. And that is according to Adrian Lau, who has done a lot of research and teaching on this subject. He kind of coined this phrase that, pain neuroscience education should be renamed pain neuroscience communication. And it really is not effective on its own in decreasing pain, but rather in addressing fear avoidance and catastrophic thinking in patients who need to become active and they're just so fearful to become active and move. And then motivational interviewing is really about addressing patients' behavior change journey and helping them along with that through inspirational communication and exploration of alternatives and choices in that health journey. Empathy is really important in motivational interviewing. The patient needs to feel like you have heard how they are experiencing their pain, their obstacles in their health journey, stresses that they have, life changes that are also simultaneously going on, and for them to leave feeling like they've just got someone else in their corner supporting them is really important in building patient rapport. Rolling with resistance is very important because this is where you learn what the patient's values are and what's important to them and what their belief system is like, and that we are going to tailor a treatment program to their preferences. And so when they become a little bit argumentative or defensive or push back on some of the information you're trying to share with them, this is a key factor telling you that they're resisting this information that I'm trying to share, or they're resisting this plan. And so at that point, you can just sit back and listen. You might take the opportunity to learn more about their perspective by asking something like, tell me more about what it feels like when ... Tell me more about how it feels. These kinds of questions are open-ended questions that allow you to roll forward and avoid that resistance. And then helping the patient figure out what they've done in the past that have worked for them when they're making steps towards goals. And that can help them build confidence in themselves and believe that they can make change now again. They've done it in the past. And you can even use that information as a guide when you're trying to support them in making this change and when you create their treatment program. And then self-exploration is really important. We can give them resources like YouTube videos, instructional videos, handouts that they can take home and read, something for them to go home and further explore on their own. That ties back into self-efficacy as well, helping them ask themselves questions that are going to get them thinking and moving towards behavior change. We can help activate patients. Patients who are activated are motivated, informed, and have the skills and belief in themselves to manage their health and advocate for themselves. And in order to help to activate a patient, you also need to know what stage of behavior change they are in. And to understand that, it's important to let the patient tell their story. And one thing that you might say to help them tell you their story, let's say if it's about their back pain, you could ask them to tell you what they already know about their back pain. And then to build collaboration and rapport, you can further ask, once you have their story, you can ask permission to also give in your input and your perspective. Would it be okay, like for example, you could say, would it be okay if I tell you my thoughts on the subject? And this opens a door for a collaborative relationship. And that's really important to patient-centered care because patients are the ones that know their bodies the best. They come through that door and they know all the quirks of their body, what has worked for them in the past, what it feels like to have their pain, what impacts their pain, what makes it better. They have things going on in their lives that we may not know about. They may not share it with us, even if we have good rapport with them. And so they're a really important person on their healthcare team. And so the more that we understand those things, the better we're going to do in managing their care, because we can combine our skills and knowledge as physical therapists with their expertise on their own body to give them really good patient-centered care. So really good patient-centered care is specific, and that includes outlining the active ingredients for their treatment plan and how that relates back to their goals. So being able to describe the specificity of the intensity of their program, how long they're going to do it. Is this a forever thing or is this a few weeks type of thing? You know, what are they in for? And how long are they going to do this every week? Is it every day? Is it every other day? These are the things that patients come in and they want to know. What am I going to be doing for how long? What's the outcome going to be? Does it relate to what they want or what we think is best for them? We've got to figure out how to combine those two goals. A patient's role in meeting their goals is something that needs to be addressed from day one to help a patient understand that their performance of their treatment plan outside of the clinic is their responsibility and something that's going to affect their outcomes. And a lot of the research that has been done in physical therapy points to long-term commitments to exercise being very meaningful. We know that we can't just have a 3-month exercise program and then call it quits and have lasting effects for years. This is truly a behavior change that needs to be maintained over a lifetime. It's a lifestyle change, and that is part of what we want to communicate to a patient and help them understand that this is within their control, and their role is that they're going to do it. We're not going to do it for them. We're going to educate them and help them make this change and provide support and tools. And at the end of the day, for them to have long-term benefits, exercise is really important, and overall health, and it needs to be maintained over a long period of time. Understanding how to combine motivational interviewing and pain neuroscience education has a few prerequisites. And the first one is that you must understand pain mechanisms. And I will say that this is something I'm still trying to wrap my head around. We learn it in school and you hear about it, and there's still questions that come up. And so understanding pain mechanisms and being able to describe it in a way that's simple to a patient is something that needs to be practiced from our point of view as physical therapists. And I think once you have that knowledge in the practice, it's probably easy. However, I've found it to be difficult as a student because I'm still trying to understand the anatomy and the kinesiology of it, and being able to explain it in a way to patients that's easy is still challenging for me. So that is one prerequisite. Being able to have open-ended discussion with a patient is important, as we've already reviewed with how to use motivational interviewing. And then we also have to use some sort of behavior change theory. We need to know what stage of behavior change a patient is in before we can kind of move on. We know that pain neuroscience education is not useful in the pre-contemplation stage of behavior change when a patient really isn't aware or addressing the fact that they might have a problem in the first place. And then asking for consent is important when we're using pain neuroscience education because it's typically given in a way that is like a lecture. So a medical professional is lecturing to a patient who doesn't know anything about this, and it's not really a collaborative conversation to have. And so by allowing permission before giving that lecture allows the patient to have more autonomy in choosing to have this information as part of their plan of care. Facilitate the patient leading this conversation. Allowing the patient to kind of struggle through voicing the reasons for their change gives them a feeling of control and autonomy. And it's them leading their therapy session to what's important to them. So questions that you can ask to help patients along with this are examples would be, what would you like to see different about your current situation? What makes you think you need to change in the first place? What will happen if you do not change? And what would be different if you complete this therapy program? This is going to lead to an open-ended conversation that is cyclical, that will allow you to build rapport with the patient and get to what's important to them. And then motivational interviewing combined with the pain neuroscience education might look like phrases that are similar to the motivational interviewing, but relate back to pain. So, what would be the good things about changing your way of dealing with pain? Or what would your life be like 3 years from now if you changed the way of dealing with pain? What do we say to a patient that comes in who says, I'm not ready to make change? I don't want to do this, but I'm also so tired of being in pain. And I wish I could just take a pill to make this better. Or, I take this medication and it makes me feel better. This is the only thing that helps. And what is that clicking sound when I do this? What does that mean? Does that, are my bones rubbing together? Am I having wear and tear that's causing me this pain? Or I am just doing this because my doctor told me that I need to try physical therapy first before we talk about surgery. How do you, as physical therapists, how do we have this conversation with patients who say things like this? And the goal is to help patients develop a reason for changing. And we can help them develop that reason by encouraging self-exploration. And we can always leave a door open for future conversation. And it's important to always provide an out. At the end of the day, we're not going to change where the person is, in that moment. If whatever stage of behavior change they're in, we might not be able to change that. However, we can plant seeds and look for teachable moments. And when we are seeking for, or when we're seeking teachable moments, we're looking for ins in the conversation of where a person says they want to be and where they're currently at, and then asking those questions, those motivational interviewing questions of, well, do you see that you say you want to be here, but yet this is the behavior that you're choosing. What do you think you need to do to get here? And what do you think are other options besides, and you could say the pill or the surgery? What would it look like if you started physical therapy today? And how would that be different? So some of those questions that we've already outlined can be used at this point when you're talking to a patient. When a patient is in the pre-contemplation stage of behavioral change and you're looking to plant seeds, there are a few things that you might want to say to help move things along. And the first thing that you'd want to do is to validate that patient's experience by saying something like, I can understand that you have little hope left for any new treatment. Or it makes sense to target the cause of your pain, and we have the same goal. What do you think is causing the pain? And then it's important to let the patient know that they have a choice in the matter, that they can give consent to treatment or decide not to give consent. And you can let them know the risks of not continuing with physical therapy at this time or the benefits of continuing with physical therapy at this time. At the end of the day, they have the choice and the door is open for them to return when they do feel ready. In some of the articles that I read, I really liked the idea of communication as not necessarily verbal communication. It could be communication in the form of worksheets or pro and con lists. It could be something that the patient takes home and looks at. And so being able to help the patient kind of figure out what it is they're concerned about and kind of organizing it in a way where they could kind of step back and look at it so that they can figure out what it is that this is kind of the point at which you're helping them develop an awareness around the problem. What is the problem? What is it that they're concerned about? These are going to lead to the reasons of why they'd want to make behavior change. And so they might not have an idea when they're talking to you about what this will all look like, but giving them something like a worksheet that you create, we don't necessarily have to use like fancy tools. We could write up an easy pro and cons list that a patient takes home and they fill out on their own. And just the act of you giving them this like worksheet to fill out at home, even if they don't do it, it's a form of communication. And it's still a choice for them to not do it or to do it. But that is how you might facilitate self-exploration. In this last slide for communication during the pre-contemplation stage of behavioral change, there are a few other points that Nice et al. Points to in their research article of things that you would want to address at this stage of behavioral change. And in his article, there are examples of phrases to use for each of these points. In the next slide, we're going to continue on to talking about the contemplation and preparation stages of behavioral change and how we'll communicate to build patient rapport and treatment adherence. At the contemplation stage of behavioral change, the patient probably has an idea of what they're concerned about at this point. However, they may not have the confidence or they may fear their pain or re-injury, and that might hold them back from making some changes. And so this stage is going to include some of the same things that the pre-contemplation stage included, like validating the patient's experience, acknowledging the patient's control over their choice in consenting to treatment or not. And it might be to further explore and clarify why they want to make change. And then they can further deal with their pain experience. So let's say we're going to go back and use some of the worksheet tools that we talked about. And you have this worksheet that you created, and you might say something like, for example, using this worksheet, what is one benefit of trying to readjust? Or what is one drawback of trying to readjust? And then you can ... whatever it is they're trying to readjust. Another question you could ask is, how would changing the way you deal with your pain impact upon your life in the short and long term? And then, of course, you want to continue encouraging that self-exploration. So this point, you might even encourage doing that with your support, with the patient's support system. So having the patient go home, and if it's their wife that they live with or husband, and you could say, would you be willing to share this with your significant other and maybe talk to them about it and explore this with them? A patient is going to want to identify who can help support them through these changes, and they're going to need to figure out what kind of support they need when they're moving into the preparation stages of behavioral change. And this is when you're going to want to begin helping them make change, actually take steps towards their goals. And so you might say something like, for example, It's great that you feel good about your decision to change from short-term relief to more sustainable solutions, and you're taking important steps to regain control over your life. And this is according to the Nice et al. Article that has the examples that I spoke about earlier. There are actual examples of things to say for each behavioral change. And so you also want to say something like, so the initial goal is to try to stop relying on short-term relief, as you now understand that short-term pain relief rewards your brain in producing the pain and sensitive alarm system. So this is going back to combining motivational interviewing and pain neuroscience education, and also delineating the difference between short-term answers and long-term answers. So for example, short-term relief might come from those medications or massage therapy, something that is going to take care of the pain in the moment, but it won't last. And so here is your opportunity to revisit the benefits of long-term change and start educating the patient on the maintenance program, the maintenance portion of behavioral change and what that means. What is the difference between maintenance and termination? So sometimes I've noticed that with patients who come in and they want to know, how come I have to do this every day? Can't I just do it like 2 times a week, this exercise that you're giving me? And I've gotten to the point of explaining it this way. And I'll say something like, well, we need repetition and practice for something to become automatic. You've been doing it this way for so long, every single day when you do it, that this is how your body does it without you even thinking about it. But in order to do it differently, you have to retrain your brain. And so you're going to have to do it every day and repetitively and over so that the practice helps make your brain look at it like, this is just my new way of moving, and this is how I'm going to move automatically. At the contemplation stage of behavioral change, the patient probably has an idea of what they're concerned about at this point. However, they may not have the confidence or they may fear their pain or re-injury, and that might hold them back from making some changes. And so this stage is going to include some of the same things that the pre-contemplation stage included, like validating the patient's experience, acknowledging the patient's control over their choice in consenting to treatment or not. And it might be to further explore and clarify why they want to make change. And then they can further deal with their pain experience. So let's say we're going to go back and use some of the worksheet tools that we talked about. And you have this worksheet that you created, and you might say something like, for example, using this worksheet, what is one benefit of trying to readjust? Or what is one drawback of trying to readjust? And then you can ... whatever it is they're trying to readjust. Another question you could ask is, how would changing the way you deal with your pain impact upon your life in the short and long term? And then, of course, you want to continue encouraging that self-exploration. So this point, you might even encourage doing that with your support, with the patient's support system. So having the patient go home, and if it's their wife that they live with or husband, and you could say, would you be willing to share this with your significant other and maybe talk to them about it and explore this with them? A patient is going to want to identify who can help support them through these changes, and they're going to need to figure out what kind of support they need when they're moving into the preparation stages of behavioral change. And this is when you're going to want to begin helping them make change, actually take steps towards their goals. And so you might say something like, for example, it's great that you feel good about your decision to change from short-term relief to more sustainable solutions, and you're taking important steps to regain control over your life. And this is according to the Nice et al. Article that has the examples that I spoke about earlier. There are actual examples of things to say for each behavioral change. And so you also want to say something like, so the initial goal is to try to stop relying on short-term relief, as you now understand that short-term pain relief rewards your brain in producing the pain and sensitive alarm system. So this is going back to combining motivational interviewing and pain neuroscience education, and also delineating the difference between short-term answers and long-term answers. So for example, short-term relief might come from those medications or massage therapy, something that is going to take care of the pain in the moment, but it won't last. And so here is your opportunity to revisit the benefits of long-term change and start educating the patient on the maintenance program, the maintenance portion of behavioral change and what that means. What is the difference between maintenance and termination? So sometimes I've noticed that with patients who come in and they want to know, how come I have to do this every day? Can't I just do it like 2 times a week, this exercise that you're giving me? And I've gotten to the point of explaining it this way. And I'll say something like, well, we need repetition and practice for something to become automatic. You've been doing it this way for so long, every single day when you do it, that this is how your body does it without you even thinking about it. But in order to do it differently, you have to retrain your brain. And so you're going to have to do it every day and repetitively and over so that the practice helps make your brain look at it like, this is just my new way of moving, and this is how I'm going to move automatically. This slide highlights one model for behavioral change that the Kenneth L. Miller article describes and uses in their research. And it just talks about the different phases of behavioral change and defines each phase. So thank you everyone for running through this presentation on communication. I've learned a lot about communication during my time in this clinical rotation at PIH, and you guys have all helped kind of encourage me, and you've listened to me and mentored me similarly to how this presentation discusses communication with patients. I feel like you guys have all given that to me as a student here. So I really appreciate all of you. Some things that I'm going to take away from this clinical rotation are some improved hands-on skills from Tony and Mike. They've both taught me different hands-on skills such as mobilizations and soft tissue massage and mobilization. Tony's taught me a lot about her melt technique and the other systems in our body that play a large role in how we feel and move. And Mike has taught me how to look at my movement systems diagnosis that I give, and when something doesn't feel right, when something doesn't fit when I'm doing an evaluation, he's really helped me to step back and kind of figure out what my differential diagnoses are. And he's helped me listen to that feeling of, okay, this doesn't fit. What else could it be? And he's helped me step outside of that box and use the ICF classification as another tool to help me fill in those gaps. You all have each given me some advice while I'm here, and I really appreciate all of those pearls of wisdom. You each, I think, have given me at least one, so thank you so much. I appreciate this opportunity to be here, and I hope you enjoyed my presentation. Good luck, everyone.